أعوذ بالله من الشيطان الرجيم وبشر الذين آمنوا وعملوا الصالحات أن لهم جنات تجري من تحتها الأنهار كلما رزقوا منها من ثمرة رزقا قالوا هذا الذي رزقنا من قبل وأتوا به متشابها لهم فيها أزواج مطهرة وهم فيها خالدون إن الله لا يستحي أن يضرب مثلا ما بعوضة فما فوقها فأما الذين آمنوا فيعلمون أنه الحق من ربهم وأما الذين كفروا فيقولون ماذا أراد الله بهذا مثلا يضل به كثيرا ويهدي به كثيرا ما يضل به إلا الفاسقين صدق الله العظيم.
Yeah, now Sean, you can carry on. Thank you.
Okay, thank you very much. So my name is Omondi, and I'll be taking us through the case presentation for today. So I'm presenting AM, a 3 months and 2 weeks a male baby was admitted 2 months ago and resides in Machakos. He was accompanied by his caregiver, MW, who was his mother. He came in presenting with a 1-week history of yellowness of the skin and a 1-day history of convulsions. So the patient was relatively well until 1 week prior to admission, when the caregiver reports that the patient had yellowness of the skin that went on for the aforementioned time frame. It occurred suddenly and was progressively worsening, had no exacerbating or relieving factors, and was present throughout. And the patient had no episode of being symptom-free. It was associated with a history of similar symptoms that went on for 1 week and spontaneously resolved. There was no associated history of change in stool color. There was an associated history of change in stool color that changed from green to pale and was present throughout. There was a change in urine color to dark yellow. There was no associated history of diarrhea, no fever, no change in urine output, and urea. A week prior to admission, the caregiver reports noting 1 episode of blood mixed with stool, and this was associated with a discolored patch of skin on the right hemithorax that was warm to touch. There was no associated epistaxis, no hematemesis or hemoptysis, and there was no reported weight loss. The caregiver reports a 1-day history of convulsions, and prior to the convulsions, the patient had fed and had no exposure to any loud noise or any flashing lights. The patient was not lethargic and had no shortness of breath or history of trauma to the head. While convulsing, the caregiver noted jerky movements of the hands and legs with no abnormal posturing, no vocalization. However, there was a loss of blood sphincter control, and following recovery, the patient had no neurological defects, and there was a 2-minute interval between the 2 episodes of convulsions that occurred prior to admission. The caregiver affirms that there was no history of travel and no history of exposure to any similar symptoms. So for the past medical history, the patient has a prior history of admission, spending 1 week in the newborn unit due to the same experience, had no previous surgeries, and had no known food or drug allergies, and had no prior blood transfusion. For the birth history, the patient was delivered at 3.5 kilograms via spontaneous vaginal delivery at 40 weeks corresponding to term, and had an APGAR score of 8, 9, 10. For the antenatal history, the mother's first antenatal clinic visit was at 16 weeks. An anomaly scan was done, and the results showed that the liver was normal, that the fetus was normal. The blood pressure and sugar levels throughout the pregnancy were also normal, and iron and folic acid supplementation was given. She cannot recall the doses, however. No calcium or vitamin D supplementation was given. The mother denies any use of traditional herbal remedies throughout the pregnancy and prior to it. The mother reports a history of a urinary tract infection for which nitrofurantoin was given at 39 weeks gestation. There's also a history. The mother affirms a history of paracetamol use during the first trimester of pregnancy. For the developmental history, the mother reports that the baby supported his head at 3 months, and at 2 months could stand with support, and at 2 months could also grasp objects, and at 3 months could follow the objects with the eyes, and at 3 months could recognize the mom. This is consistent with the normal developmental history for his age. For the immunization history, the patient is up to date with all immunizations, however, was due for the 14 weeks vaccination at the moment of clerking. For the family social history, he's a firstborn and there is no reported consanguinity as the mother and father come from different parts of the country and different communities. There's no history of chronic conditions within the family. There is no similar conditions within the family. The grandmother, the paternal grandmother, is hypertensive and diabetic, as well as the maternal grandmother, and SHA is active. For the physical examination, I conducted a physical general examination.
Sean.
Yes, Dr. Laving. Yes.
Let's stop there in case anyone wants to ask any questions on the history. Okay, any comments, any questions on the history? Excellent. Fatuma, well, there's a Fatuma first. Is asking a question. Was we be able to stand at 2 months with support? What do you think, Sean? And you said it's normal milestones.
From the report, he could stand at 2 months with support. I know that's not consistent with that age. It's not consistent with that age.
Yeah, and yet you said it is normal.
As per what I thought, I reviewed it objectively relative to the other milestones.
So remember, sometimes you have to be a bit critical of what parents tell us. You record everything, but then sometimes you have to think through and decide, is this really normal or abnormal? Okay. So good point, spotted by someone. There is a question about when was the previous admission. So you mentioned it. When was it?
The patient was admitted 1 week after delivery. Was admitted 1 week after delivery.
All right, good. And there's a comment about nutrition history.
So as per the mother's report, the baby was feeding well up until 1 week prior to admission, 1 month prior to admission, when the baby started experiencing the yellow discoloration of the skin. That is when he started feeding poorly, but he's still being exclusively breastfed. But the mother reports that there were some disturbances with feeding prior to admission.
So I think what June wanted to know is this an exclusively breastfed baby or not? Okay, so I think that is what was missing. Yes. Exclusively breastfed baby. So that's good. So see, good comments from your colleagues. History is otherwise good. So remember the presenting complaints was jaundice, right? Yellowness of the eyes.
Yes.
Okay, and to your colleagues, I mean, so he talked about the yellowness of the eyes. He described it well. When he described any associated symptoms, there were some things that were slightly off for an infant, but it's okay. This is how you learn, right? Then you mentioned the color of stools.
Yes, I did, Dr. Laving.
Okay, so you mentioned color of stools and the urine becoming dark. Now, why? Let's see. Who's here? In the participants, Arshia, we were with you in the morning. What else would he should he have asked about? He's asked about color of stool, color of urine. As far as the jaundice is concerned, what else do you think he should have asked about?
The other GI symptoms, like maybe vomiting, any changes in the bowel, like any diarrhea, constipation, and so on, like the other GI symptoms.
Okay, good. So other GI symptoms, itchiness. Oh, Emmanuel, do you think a 3-month-old baby can be itchy?
No.
It's difficult, yeah. However,
Yes, difficult.
it can happen. This is the one I was waiting for. So, bleeding tendencies. Who is this? Because on my whatever it just says F. I don't know who F is. Why do you think F is asking about bleeding tendencies, Sean?
I think F is asking about bleeding tendencies because of the synthetic function of the liver in relation to the clotting factors.
Excellent. So this is something that we must always ask. So here we have talked about the history, presenting complaints, and then you've described the symptoms well, and associated symptoms. So bleeding tendency is now a possible complication of liver disease, isn't it? So you're looking at now complications of a potentially underlying disorder. All right, so that would be a good thing to ask. All right, good. Otherwise, good history. So let's move on to the examination.
So I performed a physical general examination on Ariella Mumbi, 3 months, 2 weeks infant, and the following are my findings. The patient was in fair general condition, dressed in civilian clothing, surrounded by clean, dry beddings, and was in no evident respiratory distress. On examination, sclerosis was present. However, there was no cyanosis. There was no lymphadenopathy across all peripheral nodal groups. The mucous membranes were moist, and no peripheral or central pallor was noted, and skin pinch was immediate. On abdominal examination of Ariella Mumbi, on inspection, the abdomen was flat, moving with respiration. There was no flank fullness. The umbilicus was inverted, and no scars were present, and there were no distended vessels over the abdomen. On light palpation, there was no tenderness or obvious masses noted. On deep palpation, there were no deep masses, no rebound tenderness, and no guarding or rigidity was noted. The spleen was not palpable, and the kidneys were not bimanually palpable, no megaly was noted. On percussion, the abdomen was tympanic, and on auscultation, the bowel sounds were present and normal, and no bruit were heard over the abdominal aorta or the renal arteries. On cardiovascular examination,
all right,
on inspection.
So, hold on, Sean. So, abdomen will take you down on the CVS and respiratory. Was there anything abnormal that you noted?
No, there was nothing abnormal noted on the other examination.
Okay, fine. So we move on. Next slide.
So the investigations that were carried out. So Ariella had an intraoperative angiogram that was done, and they noted a distended gallbladder and a cirrhotic liver.
Is it the first investigation that was done when a baby was admitted to the ward?
No. The first investigation that was done was the complete blood count.
Thank you.
So on admission, the complete blood count was done, and it was noted that there were elevated white blood cells at 16.19. The lymphocytes were at 12.36, which is high. The neutrophils were at 16.3% on the differential count, consistent with a low profile, while the lymphocytes were at 76.3, which is indicative of lymphocytosis. The MCHC was at 31.8, and the PCTs were 3.37. The liver function tests were also done, where we had an AST of 359.2, that is high, and an ALT of 306, that is also high, and an ALP of 954.9, which is high, and a gamma GT that was greater than 650, which is consistent with a high profile, and a total bilirubin of 246.45, which is high, and a direct bilirubin of 184, which is high. And the picture being painted here is that this is conjugated.
Well, don't say it. I want to ask that question.
Okay, Dr. Laving.
So who is next? Now there are mashallah, so many Abdis here. Okay. Alia, I know you. All right. So Alia, please interpret those liver function tests.
Hi.
Hi.
So for there's elevated total bilirubin and the direct. That means there's direct hyperbilirubinemia, conjugated hyperbilirubinemia, indicative of obstructive or cholestatic jaundice.
Okay, good.
Yeah, and of course elevated SPLT, which are markers of inflammation, together with the gamma DGT is also very highly elevated. A marker of cholestasis also.
Good. So your transaminases are elevated, so that's a sign of usually liver parenchymal injury or inflammation. Okay, and your gamma GT being high is a sign of, as you said, so a biliary tree being affected. Okay, and the alkaline phosphatase is also high. So we have a picture of, as you mentioned, a cholestatic jaundice with elevated transaminases and an elevated gamma GT. Okay, good. That's the interpretation that is going to be required even when you in your OSCE, for example, station, and you get blood result or any result that's there, you should be able to state if it's high, if it's normal, or if it's low. You need to state it, and then you try to interpret it. It's very important. The way you did it is very good. Okay. Let's move on. Next slide, please.
And the CMV IgG was reactive. To close
what
out
about the
interpretive,
CMV IgM?
It was not done as per the files. I went into the files and checked. They had not done an IgM profile, but the IgG was reactive.
All right, that's fine.
The intraoperative cholangiogram was done, and they found a distended gallbladder and a cirrhotic liver. They also did a CT scan of the head and they found features of multiple brain infarcts and bilateral chronic parietal subdural collections and ventriculomegaly. A core needle biopsy was done, where they noted expansion of portal tracts with fibrous tissue, and there was marked bile ductular proliferation at the periphery of the portal tracts. Bile plugs were present within proliferating ductules. The portal tract was showing mild to moderate chronic inflammatory cell infiltrates, and giant cell transformation of the hepatocyte was also noted. There was no granulomata or microorganisms noted on the core needle biopsy. So for the medications that the patient was on at the time of clacking, the patient was on ceftazidime, 50 milligrams per kg IV, was also on ursodeoxylic acid, 58 milligrams, and was on prednisolone at 4 milligrams, and epilim at 70 milligrams, 2 milligrams per oral, and baclofen 2.5 milligrams, and ondansetron 0.6 milligrams at the time of clacking.
So, Sean.
Yes, Dr. Laving.
If I were to ask you the medications and why each medicine was being prescribed and given, would you be able to answer that question or not?
I'd struggle with some of them, but some of them I'm aware.
No, that's fine. So it's important. So when, for example, and this will be helpful not only in your clerkship now and in future as well, is to ask yourself, why was each medicine prescribed? it's okay to ask yourself to try and find out. It's okay to ask your registrar or your resident, and it's also okay to ask the consultant. So don't take things at face value. Okay, it's important to ask why was baclofen being prescribed, and what is the role of prednisolone in this baby with cholestatic jaundice. I don't want you to answer this now, but this is for future for all of you. When you go out there, it's always important to look at the T-sheets and politely ask the registrars and find out what is it that why were the medications prescribed and what is the role of each medication. And sometimes the medicine might, if you don't look at the T-sheets, you will babies patients keep on getting medications that sometimes were supposed to be for a specific time duration, and people forget to write the timelines and they keep on getting it, and vice versa. Sometimes the medicine, let's say maybe the baclofen is supposed to be given for several months, and after the initial week or so, there's no space, and maybe the nurses stop giving it. So it's very important to look at the T-sheets as well and to ask yourself that question as to why each medicine has been prescribed. Okay, good. Next slide, please.
That is the end of my presentation.
All right, thank you. So there's a good presentation, good history, and again, you got good input from your colleagues. Okay, so that's why I repeat this all the time, that present amongst yourselves in your groups. It's very important. Learn from each other, and then you can present to the registrars and then consultants. All right, so now that we have a 3.5-month-old with features of cholestatic jaundice, we shall ask who shall we ask? Okay, Diana, are you there? Diana? No? Felix, Koich? My question is, I know you have an intraopcholangiogram finding as well, but what goes through your mind? What are your differential diagnoses at this point in time? Diana and Felix don't want to answer? Who would like to? Okay, so I'm seeing a few. So sepsis, okay, biliary atresia. All right. Okay, choledochal cyst, good. So late onset neonatal sepsis leading to chronic cholestasis. Yeah, it's a possibility, but did this child come in with a fever? There was no fever, right? But it's important to think about sepsis, or maybe not. And in a sick-looking child, sepsis becomes one of the earlier differential diagnoses. You have to think about sepsis, but this wasn't a sick-looking baby, from what we were told. Okay, all right. So it's good to think about. All right. So I can see some other differentials coming in as well. Autoimmune liver disease, a bit unusual in this age group. Yep. So galactosemia is a possibility. Viral hepatitis becomes a possibility. Malignancies, again, can happen, uncommon, but can happen. And then, of course, so infections, so the torch infections, we have to think about that as well. Now, in this particular baby, we also had some other symptoms there. So there were convulsions. And of course, we were told about the imaging findings. So we need to think slightly broader than if it was just cholestatic jaundice. Okay, good. I can see some of the differentials have been listed. All right, that's good. So the thought process must be there. Now, hemolytic disease, would it give you a conjugated or an unconjugated hyperbilirubinemia? Paul, it's unlikely to give you conjugated, right? It's probably going to be unconjugated. Right, so there is another differential that has been stated is hypoxic ischemic encephalopathy. So is it possible that at the time of birth, although we were told, and shown SVD usually stands for spontaneous vertex delivery, okay, so we're told and ABGA scores were good, but because of the convulsions that happened and the liver injury that's there, it's a possibility. So although it's from the CT, that's what you have said, where F is HI from CT brain, but it's a possibility that there was maybe some form of hypoxic injury at birth, which has affected both the brain and the liver. So that's a good thought process. All right, good. We move on to the case presentation. But well done.
Thank you, Dr. Laving.
Assalamu alaikum, everyone. Can someone please confirm if I'm audible?
Loud and clear.
All right, great. So I'd first like to appreciate Dr. Laving for taking some time out for this case and to listen to us and give his feedback. So yeah, I am Ghulam MBChB level 5, and this evening I'll be taking you through prolonged jaundice in infants. So we'll try to make this session slightly interactive if you guys oblige. I will ask a few questions that shouldn't be too difficult for us, and I'd prefer if you unmute and speak, but you could also put it in the chat box, that's all right. And you could also interrupt me at any point if you have a question. So while many cases of jaundice in the earlier periods of life are harmless, persistence of it beyond the expected period can be a sign of some serious underlying pathology. So let's look at how we can recognize and manage this early. So let's go through some of the definitions first. What is jaundice? Jaundice is the yellow discoloration of the skin, interstitial fluids, and the sclera of the eyes due to hyperbilirubinemia, which is levels above 85 micromoles per liter in kids. We have prolonged jaundice, which is the persistence of visible jaundice beyond 2 weeks in term infants or 3 weeks in preterm infants. Then we have hyperbilirubinemia, which is higher than normal levels of bilirubin in blood. So the normal levels in children being about 3.5 to 20.5 micromoles per liter. Then we have a common term, icterus, which is the yellow discoloration of the sclera. This is easily appreciated as the sclera is white and also has elastin that has quite a high affinity for bilirubin. Then we also have cholestasis, which is the impairment of bile outflow such that the contents of bile spill into blood. So if anyone could unmute and tell me the 3 main components of bile. Bile has 3 main components. Anyone? Okay, seems like no one's able to answer that. So, yeah. Hello?
Bile acid.
Yes, bile acids. What else?
Bile pigment.
Okay, and the last one? Okay, I'll answer that for you. So,
Water.
So bile has 3 components, the bile acids or the bile salts. So they're used to usually emulsify the fats for digestion. Then we have bilirubin, the byproduct of heme degradation. And finally, we have cholesterol. So let's go through bilirubin metabolism briefly. This is a concept that we ought to know. So it all starts with the red blood cell. So the red blood cell, upon reaching the end of its lifespan, it is taken up by the macrophages of the reticuloendothelial system, which is the liver, spleen, and the bone marrow. The spleen does the majority of the work, but in this case, we'll talk about the liver. The Kupffer cells, which are the resident macrophage in the liver, they usually take up the red blood cell. The hemoglobin in the red blood cell is broken down into the heme and globin component. Heme is further broken down into bilirubin by 2 reactions, catalyzed by enzymes biliverdin reductase and heme oxygenase. The end product is bilirubin and iron. The iron is combined with the globin that's formed initially and is recycled for erythropoiesis. The bilirubin then in this form is unconjugated, right? So the unconjugated bilirubin is usually lipid soluble and readily binds to albumin in the blood. However, the hepatocytes in the liver usually have quite a high affinity for this molecule. Therefore, it's taken up by facilitated diffusion, where it undergoes a process known as glucuronidation by a family of enzymes known as beta UGT or BUGT, which is basically uridine diphosphate glucuronosyl transferase. So in this process, it's converted to conjugated bilirubin. Then the conjugated bilirubin is water soluble and continues its journey into the small intestine. A small amount of unconjugated bilirubin also goes through, and unconjugated bilirubin, being lipid soluble, is readily reabsorbed by the enterocytes. So it goes back into the liver through a process known as enterohepatic circulation. The conjugated bilirubin continues and is converted to urobilinogen by gut bacteria, then further converted to stercobilin by gut bacteria also, giving feces its normal characteristic color. Some of the urobilinogen goes back into the liver and goes into blood, and the blood's filtered by the kidneys, and urine gets its color from the characteristic urine urobilinogen, the yellow characteristic color. So a defect in any of these steps will lead to bilirubin accumulation and the clinical appearance of jaundice. So let's go through a concept known as physiological jaundice, which is normal jaundice. So how does this happen? So basically it happens because babies are still adapting to life outside the womb. They have a shorter red blood cell lifespan, so more heme is broken down. The liver enzyme UGT is still immature, which slows down bilirubin processing. And also they have increased reabsorption in that there's few gut bacteria combined with the high beta-glucuronidase concentrations compared to adults. This causes more enterohepatic recycling. So the peak is usually at day 3 to 5 in a term neonate. However, Asian infants have slightly delayed peak at about 7 days. It resolves by about 1 to 2 weeks as the liver matures, and therefore it's pathologic if it lasts greater than 14 days in a term or 21 days in a preterm infant, as mentioned prior. Okay, sorry. So I'd like to ask definition of two concepts. There's something known as breast milk jaundice and breastfeeding jaundice. So could someone please tell me the difference or the definition of any term?
I could try.
Yes, please go ahead.
Breastfeeding jaundice is caused by insufficient breastfeeding, while breast milk jaundice caused by increased levels of beta glucuronidase in maternal breast milk.
Yes, that's perfect. That's exactly the definition of the term. So breastfeeding jaundice appears in the first week due to inadequate milk intake and subsequent mild dehydration. Then we have breast milk jaundice, which starts at about day 5 to 7. And this is due to higher beta-glucuronidase levels in breast milk. Therefore, the bilirubin reabsorption is increased. Right. So let's go on to cholestatic jaundice. So conjugated hyperbilirubinemia is also known as cholestatic jaundice. It's whereby the conjugated bilirubin makes up 20% or more than 20% of the total bilirubin levels. This usually affects roughly 1 in every 2,500 infants. And locally at Kenyatta National Hospital, a thesis done by one of our own students, her MMed thesis in 2019, found that about 9% of infants with prolonged jaundice have conjugated hyperbilirubinemia. The current NASPGHAN guidelines also recommend that every infant with jaundice lasting beyond 2 weeks should be evaluated for cholestasis. This is to avoid missing serious liver disease. All right, okay, we'll just skip the question here because we've mentioned all the etiologies when we did the history. So we have infectious causes such as idiopathic neonatal hepatitis. We have the torches such as toxoplasmosis. We have cytomegalovirus. We have Hep B and C. We have sepsis, Doc mentioned. We have UTIs, such as the ones that E. coli causes. Some structural anomalies, such as biliary atresia and choledochal cysts, which we'll look at a bit in detail. We have endocrine, such as hypothyroidism, whereby hypothyroidism usually decreases bile flow and bile salt excretion by up to about 50%. Then we have some metabolic causes, galactosemia and tyrosinemia being some of them, whereby there's the galactose and tyrosine metabolic defects. Then we have alpha-1 antitrypsin deficiency, whereby there's accumulation of abnormal protein alpha-1 antitrypsin. that causes liver damage. So the pathology is usually different to the one that's caused in the lung. The lung pathology is slightly different to the liver one. Then we have hemochromatosis. We know that's the abnormal accumulation of copper. We have some congenital anomalies such as Alagille's. Alagille syndrome is basically reduction in the number of bile ducts, therefore resulting in a poor bile outflow. Some toxic causes such as parenteral nutrition associated, and of course, we all resort to idiopathic if none of them work out. All right, so we have a stool card on the left. We have group 1 on the top and group 2 on the bottom. Could someone please tell me which of the groups they think is normal? Is this group normal or is this group normal for stool of an infant? It's a simple one.
Hello, can I
Yes,
can I
please.
try? Okay. So I think the abnormal would be 1, 2, 3, and then the normal would be the bottom half 4, 5, 6.
Yes, good. So as a parent who's not literate in this matter, 4, 5, 6 would also look abnormal to them because they are not aware of the normal stool color, especially if it's your first child and so on and so forth. So checking the baby's stool color every day for the first month after birth is very important so that we can screen for biliary atresia. Parents are not reliable observers as of now due to lack of the education. Clinicians better at detecting the stool. Therefore, the stool color card would improve the early case findings. So how do these patients present clinically? Real quick, can we have a few clinical presentations? Just go on and unmute and say, or you can write them in the chat.
Dark urine.
Dark urine, what else?
Pale stool.
Pale stools, another one. The general presentations, or the most likely, the common one.
Poor feeding. Ability.
Hepatomegaly.
Hepatomegaly, good. What else?
Lethargy.
Lethargy is also correct. So good, that's most of them. So we have jaundice, usually greater than 2 weeks as per the definition we mentioned. We have acholic stools, which is basically pale stools. We have dark urine, lethargy, irritability, bleeding tendencies due to the liver being affected. We have icterus, of course, pallor, hepatomegaly as mentioned, failure to thrive. Sometimes we could have hypotonia or the baby could look totally normal. So this is just a small algorithm we can use in diagnosing. So if a jaundiced infant between 2 to 8 weeks old is noted, and there's a classical history that includes pale stools and dark urine, we check if they have an acute illness process ongoing. If they do, of course, we should treat that first. So it could be a sepsis, UTIs, could be hemolysis, could be any infection that's ongoing. If they don't, we measure the total and direct bilirubin levels. If it's greater than 20, then yes, it's cholestatic jaundice or direct hyperbilirubinemia. If not, then of course, it's the contrary, indirect hyperbilirubinemia. So we have cholestasis and indirect. Some of the causes or etiologies we could consider for direct biliary atresia, choledochal cyst, and so on. The investigations, we do the FBC, full blood count initially, LFTs, liver function test, bleeding time, albumin, glucose. We can do a urine MCS for UTIs, ferritin levels, and abdominal ultrasound, liver biopsy, among others. Then we can finally consult appropriately when needed. For the indirect part, of course, you consider the physiological causes, so breast milk jaundice and the physiological causes, UTIs, again, ABO incompatibility, hemolysis, and hypothyroidism. Investigations similar to the previous one with the addition of PBFs, blood grouping, Coombs test, because this is more hemolytic. Then, okay, we again, we consult appropriately when needed. So there are niche tests we can do and additional testing. These are good to know, not must know. So if anyone can tell me a few of the tests they think would be additional in settings that have the financial capability of doing so. So anyone can unmute and let me know.
Is the urine reducing sugars for
You're too soft. Anyone else?
I guess you meant her voice is too soft.
Oh yeah, your voice is too soft. Okay, anyway, it's fine. We'll just go through them. So we have protein electrophoresis. That's typically for alpha-1 antitrypsin levels. Then we can do thyroid function test for hypothyroidism. We can do something known as sweat chloride. So sweat chloride is usually to know if there's a defect in the CFTR gene, which is the cystic fibrosis transmembrane regulator gene. So that gene usually causes bile to be more viscous. Then we have urine amino acids for tyrosinemia. We could have urine-reducing substances that include glucose, fructose, and so on. You could do urine bile acids, and finally, you could review the results of the newborn metabolic screen. So ultrasound, let's focus a little bit on ultrasound. This is best done 3 to 4 hours after fasting. That is because if you feed, the gallbladder contracts and releases bile, and we do not want that, because if the gallbladder is contracted or not visualized, then that is suggestive of biliary atresia. So if we feed and do that, then there's contradictive results that occur. So this confirms biliary atresia with a sensitivity of about 73% and a specificity of about 67%. So the presence of a triangular cord sign, so this whitish zone here, which is a fibrous echogenic cone located on the bifurcation point of the portal vein. So if we see this on ultrasound, it strongly supports the diagnosis of biliary atresia. So this raises the sensitivity and specificity sky high to about 83 and 98% respectively. Ultrasound also can identify choledochal cysts and other biliary tract anomalies. Biliary atresia, it's a disease where the bile ducts get inflamed and blocked. Therefore, they stop bile from flowing out of the liver. This affects 1 in about 8,000 babies, and it's the main cause of long-term jaundice and the most common reason for liver transplants in infants. We generally don't know how it's caused, but some postulate that it could be due to problem during development, maybe a viral infection, autoimmune, and the baby is usually well-looking, although he's jaundiced. So early diagnosis is key for this, and treatment before 60 days drastically improves the outcome. So how is it done? It's called the Kasai procedure, whereby a portion of the small intestine on the end is cut, and the distal end is attached to the liver, and then the end that was cut is anastomosed with the other part, the remnant that was cut. So it's called a Roux-en-Y connection. So that usually reestablishes bile flow in about 80 to 85% of patients if done before 8 weeks. But if done after 12 weeks, that goes down to about 20%. So we can see why early diagnosis is quite necessary. Then finally, liver transplant for late diagnosis and failed CASA is the final option. We have something known as the choledochal cyst. It's a cystic dilatation of the biliary tract, could be both intra or extrahepatic. 1 in about 15,000 is the incidence levels. Up to 2% of infants with prolonged jaundice usually have this pathology. So there's obstruction of bile flow, then eventually biliary cirrhosis occurs. Treatment is similar to the previous mention, but it's a different procedure whereby there's a Roux-en-Y choledocojejunectomy. So we can just remind ourselves here on the right, we have the right and left hepatic ducts draining into this common hepatic duct. Then the gallbladder gives the cystic duct, they join forming the common bile duct. And then finally, ampulla of Vater drains the bile and the pancreatic enzymes. We see the 5 different types of choledochal cysts here on the right. Finally, you have neonatal hepatitis, which is inflammation of the liver within the first 2 months of life, usually characterized by cholestasis. Classically, on histology, we see multinucleated giant hepatocytes. Therefore, the disease is classically referred to as giant cell hepatitis. So it's many cells, the cytoplasms combine together, and we see the nuclei of each of the cells in one cytoplasmic area or in one matrix. So that's known as giant cell hepatitis. Causes are up here, virus, mostly idiopathic, but some postulate mother-to-child viruses, torches infections, and so on. So how do we manage these patients? Of course, we do the specific cause management. For example, if hypothyroidism, we do hormone replacement. If it's cholestasis, we could treat. If it's biliary atresia, you do Kasai. Medically, we can use substances or drugs known as choleretics, so such as ursodiol. So what do? They promote bile flow. Then we have bile acid binders such as cholestyramine. Cholestyramine usually reduces symptoms, so biliary causing symptoms such as pruritus and so on. And we can care for them supportively. Adequate nutrition, of course, involve the nutritionist. Give them fat-soluble vitamins, A, D, E, and K in water-miscible form so that they're able to absorb it. And finally, as mentioned, specific treatment will, of course, depend on the etiology. A reminder that phototherapy is not effective if the hyperbilirubinemia is conjugated. We follow them up with serial bilirubin level monitoring until resolution. We do them daily if severe, but about 3 to 5 days is okay if improvement is noted. Growth, feeding, and development assessment is also necessary, and definitely early referral to pediatric gastroenterology or metabolic specialists, especially if the jaundice persists more than 3 weeks, and of course with its characteristics, pale stool and dark urine. So what can we do as a community? We can teach parents that jaundice beyond 2 weeks is not normal, and we can educate them on the warning signs. We question ourselves and ask ourselves, is the jaundice physiologic or is it pathologic? And finally, we can work together. We should have interdisciplinary collaboration, and of course, when in doubt, discuss and refer for the betterment of your patient. Small phrase there, a good doctor knows when to act, but a great doctor knows when to ask for help. When we work together, outcomes are always better. So yeah, any questions or clarifications, and that would be the end of the presentation.
Thank you, Ghulam. He's spoken like a pediatric gastroenterologist. What do you guys think?
Thank
Yeah,
you.
I can see all those acclamations, yeah? Well done, Ghulam. All right, guys. So thank you for choosing this topic. This topic is personally very close to my heart. It's because we see so many babies with prolonged jaundice who unfortunately are missed. The diagnosis is missed. More often than not, the baby will present at 6 weeks of age for the well baby checkup. Babies, as Ghulam pointed out, in many instances with biliary atresia, which is one of the most common causes we see, baby is otherwise well, and the mother might inform the nurse or the doctor that the yellowness still persists, and in the majority of the cases, the mother will be reassured and will be told to expose the child to sunlight and it will go away. And we have been told multiple times, and Ghulam has repeated it here, that any jaundice in a term baby beyond 2 weeks is not normal, it's not physiologic, it's pathological. It needs to be investigated. And again, biliary atresia has been highlighted. We know that he said 60 days, that's 2 months. Basically, if the intervention takes place within 60 days, the outcomes are much better. If it's delayed, then outcomes are not good. Beyond 3 months, and sometimes we see them even beyond 4 months, what happens is the surgeons are not going to touch that infant because the outcomes are not very good for biliary atresia at that point in time. And so what happens to these infants? We don't offer liver transplant. In this country, liver transplant costs about 3 to 4 million shillings outside. Most of our parents cannot afford it. And so these babies are just waiting to die. They're just waiting to die. That's the truth. Because the surgeon is not going to go in at that point in time because it's pointless. So it is really important that at 6 weeks of age, because that's the most likely age we're going to pick this up, if you see an infant out there who still is jaundiced, just follow that algorithm, the flow chart, do your bilirubin levels, and if it is conjugated, if the direct is more than 20% of the total bilirubin, you need to act fast. So get your fasting ultrasound done, and as pointed out, if the gallbladder cannot be visualized in a baby who has been fasted for 3 to 4 hours, that usually suggests biliary atresia. In my opinion, the other thing that is very suggestive of biliary atresia in your LFTs is your gamma GT. If your gamma GT is also elevated, we talked about it at the beginning, and again, a sign that the biliary tree is involved, and so you need to act fast. We have literally 2 weeks to get the surgeons on board. Our surgeons are very good, they know how to do this, but we need to get this baby to them very fast. Okay, so that's the message. That's a take-home message. Prolonged jaundice is not normal. It's not physiological. Do not prescribe phototherapy to babies out there who have jaundice beyond 14 days for a term and 21 days for a preterm baby. Thank you very much. I think we have kept our time. Oh, yes. So in jaundice less than 24, if it presents before 24 hours after birth, is also abnormal, but usually it's going to be more of a hemolytic picture. And we were talking more about cholestatic jaundice in this particular case. We can talk about unconjugated hyperbilirubinemia at a different forum, in a different forum, okay? But thank you very much. I think this was really well done. Any other questions or comments?
Before we close, could we have Khalid, the moderator, to say a few words, if that's okay with you, Doc?
Sure, and a word of prayer as well.
Yeah. Thank
Khalid?
you. Thank you very much, Ghulam, for the wonderful presentation, also shown, and thank you, Dr. Laving, for the wonderful insights on this topic. I hope most of us have learned, or all of us have learned something about the topic. From MSAUN-KNH, we thank you all for attending this session. We close with a dua. Subhanak Allahumma wa bihamdik. Ashhadu an la ilaha illa anta wa atubu ilayk.